be presenting a retrospective chart review that we conducted at Barnersville Junction Hospital in Monrovia, Liberia. The global burden of antimicrobial resistance is substantial, accounting for more than 3 million child deaths in 2022, 22% of which were in Africa. Sepsis, which is a systemic reaction to a bloodstream infection, is a leading pediatric diagnosis in MSF-supported facilities. Antimicrobial resistance makes the timely and effective treatment of sepsis much more difficult, and it leads to poorer prognoses. In 2019, an estimated 20 million children under the age of 5 died due to sepsis. So what tools do we have to respond to antimicrobial resistance? One tool in the package of antimicrobial stewardship is the Cumulative Hospital Antibiogram. This is a summary of resistance patterns from clinical samples from the same patients in the same hospital during the same period of time. The Cumulative Hospital Antibiogram is a critical tool in the surveillance of antimicrobial resistance. It tells us what pathogens are present in the population, which antibiotics are they resistant to, and what are the patterns of resistance over time, including to what degree are multi-drug resistant organisms present. However, there are some important limitations to the usefulness of the Cumulative Antibiogram. It serves as an alert system, but it's a very general overview, and to effectively guide the adaptation of empiric guidelines, additional clinical data is needed. So we designed our study to answer some of these questions. We had several questions for the study. One, are clinicians appropriately treating sepsis empirically and in targeted treatment? Two, where are patients acquiring resistant infections? And three, do clinicians need to be treating community and nosocomial acquired infections differently? At the population level, we wanted to see how the results of the study plus the cumulative antibiogram could be used to effectively adapt empiric guidelines. Before we go further, I want to review a few definitions for key terms. The cumulative antibiogram, which we've discussed already, is a summary of the susceptibility of bacteria to different antibiotics in clinical samples in the same population in the same period. So the antibiogram, otherwise known as the final result, so there's two stages of microbiology results after a sample is collected. The first stage is the preliminary result, also called the gram stain, and that's an initial classification of a pathogen from a clinical sample. It can take 1 to 2 days. The antibiogram, the final result, is the final antimicrobial susceptibility testing for that patient, and that can take 3 to 5 days or even longer to provide from the lab. Empiric treatment is treatment based on clinical signs and symptoms, and then according to guidelines. It's very broad, it relies on trial and error, and it can lead to delays, particularly when the bacteria or the resistance profile is not addressed adequately by the empiric treatment. Targeted treatment, on the other hand, is after you have microbiology data where you can effectively treat the causative pathogen of that infection. Nosocomial is what we call infections that are assumed to have been acquired at a healthcare facility. For the purposes of our study, we defined this as infections acquired after post 48 hours from admission. Community acquired are infections acquired in the community. And for the purposes of this study, we define that as any positive blood culture in the first 48 hours after admission. So our study was conducted at Barnersville Junction Hospital in Monrovia, Liberia. This was an MSF and MOH supported hospital that was operating from April 2015 until September 2022. The microbiology lab supported by MSF opened in 2019. Our study enrolled patients from July 2019 to September 2022 retrospectively, and these patients were aged between 1 month and 15 years. We began with 465 positive and eligible blood samples. That represented 444 patients. Of these, about 85% were considered eligible for the chart review. That's 377, and the remainder were excluded due to missing or incomplete chart data. So we undertook a retrospective chart review in this study. We assessed the appropriateness of empiric treatment, the appropriateness of targeted antibiotic treatment, and the presumed origin of infection based on the definitions that I reviewed already. For appropriateness, we define this for the purposes of the study as being in accordance with guidelines or being reasonable based on clinical review of expert opinion. And we had a second parameter, appropriateness, which was to assess the drug choice. If the drug choice was appropriate, then we further assessed the dose, the duration, and the route. So overall, our patients were very young and very ill. Most of the patients were under 3 years of age. The majority, 3/4, were in the ICU at some point during their admission, and almost half were severely malnourished. This cohort also faced a very high mortality rate. More than 36% of the patients passed away during their admission. Where a reason for culture was indicated, it was primarily sepsis or suspected sepsis. The culture was usually taken in the emergency room, followed by the ICU. So coming to origin of infection, we do find that more than half appear to have been acquired in the community. However, we see a very high proportion of nosocomial infections as well, which accounted for 1/3 of all the infections in the cohort. Looking at the causative pathogens, we find that community-acquired infections are the majority in all categories, except in non-fermenting bacteria, which along with gram-negative Enterobacterales accounts for the majority of nosocomial infections. The most commonly identified pathogens in this period were Klebsiella species, particularly Klebsiella pneumoniae at 23%, Escherichia coli at 11%, and Staph aureus at 9%. Acinetobacter baumannii and Pseudomonas species were also identified, each of them in 31 samples, including in community-acquired infections. We found a concerning rate of multi-drug resistant organisms in this cohort at 20% of samples. Approximately 70% of these were resistant to cephalosporins, 20% to carbapenems, and 10% to cloxacillin. Considering the appropriateness of antibiotic treatment, we reviewed nearly 1,300 antibiotic prescriptions, and please note here that the totals may represent more than one antibiotic per patient. Overall, almost 80% of empiric prescriptions were deemed appropriate. This was primarily determined by their accordance with MSF guidelines. Where the drug was appropriate, we further evaluated dose and duration. In empiric prescribing, the dose was more often too low rather than too high, and the duration was most often too short rather than too long. In contrast, we see a drop in appropriateness in targeted treatment to 66%. A larger proportion of those prescriptions were in some way not compliant with MSF guidelines, however, were determined to have still been appropriate by clinical review and agreement. Duration was most often considered to be too short and when it was inappropriate, and the dose was more often considered to be too high, similarly to empiric treatment. So let's return to our study questions. Clinicians, by and large, are empirically treating appropriately. During the targeted treatment, we see that there was a reduction in appropriateness, and we see improvement needed in this area. Patients are, by and large, acquiring resistant infections in the community. However, we did see that 1/3 acquired nosocomial infections in this cohort. Do clinicians need to treat community and nosocomial infections differently? We can say probably yes, due to the high rate of multi-drug resistant organisms, as well as the identification of unexpected pathogens in the community. At the population level, our findings do support changing the first-line treatment and also to investigate additional risk factors for multi-drug resistant organisms. So some questions remain. How do we continue to improve our antimicrobial stewardship and reduce the burden of sepsis with the tools that we have? It's one thing to develop new guidelines, however, it's another thing to figure out how to successfully implement those. We need to ask what are the challenges and the enablers of implementation for clinicians in our projects, and what kind of follow-up is needed to ensure implementation is successful. And then at the population level, coming back to the guidelines, when and how do we adapt empiric guidelines? Notable questions, especially regarding the threshold for adaptation, remain, and also whether there are risk factors that we can identify at the individual level for multi-drug resistance. And finally, how can the cumulative antibiogram be leveraged to become more useful regionally and nationally? I would like to thank the patients whose data contributed to this study, the staff from MSF and the study team, and the Liberian Ministry of Health and Social Welfare, who were very instrumental in helping us complete this study. Thank you so much.